Most patients with sarcoidosis are started on steroids, almost automatically. But what if that reflex is wrong? A new position paper is challenging one of the most deeply ingrained practices in pulmonary medicine, suggesting that long-term steroid use may be doing more harm than we think. And the real question is no longer when should we start steroids, but why are we still using them long-term? In this episode, we'll break down that paradigm shift and also review a new pulmonary embolism trial and what pulmonary artery size on CT actually tells us. These are 3 studies with direct implications for how we manage pulmonary vascular disease and inflammatory lung disease today. Welcome to This Week in Pulmonary and Critical Care Medicine. This is your weekly, high-yield review of the most important new studies in pulmonary and critical care medicine. The goal here is simple: strip away the noise. Focus on what actually changes how you practice. Let's start with pulmonary embolism. Intermediate risk pulmonary embolism sits in an uncomfortable middle ground. These are not crashing patients, but they're also not benign. You have RV strain, elevated troponin, maybe mild hypotension or tachycardia. And the question we've all struggled with is simple: is anticoagulation enough, or should we be doing more? This randomized trial directly addressed that question. They enrolled 544 patients with intermediate risk PE. These were not low-risk patients. Every patient had RV dysfunction and elevated troponin. And importantly, they also needed at least 2 signs of clinical stress, things like tachycardia, tachypnea, or borderline blood pressure. Patients were randomized to one of 2 strategies: either standard anticoagulation alone or ultrasound-facilitated, catheter-directed fibrinolysis plus anticoagulation. Now let's get to the results. The primary outcome was a composite of death, hemodynamic collapse, or recurrent PE within 7 days. And the difference was striking: 4.0% in the intervention group versus 10.3% in the control group. That's a relative risk of 0.39. Confidence interval 0.20 to 0.77. P-value 0.005. So roughly a 60% relative reduction. But here's the key nuance. This wasn't driven by mortality. It was driven by prevention of clinical deterioration. Cardiorespiratory decompensation occurred in 3.7% with intervention compared to 10.3% with anticoagulation alone. That's where the signal is. Now let's talk safety. Major bleeding at 7 days was 4.1% in the intervention group versus 2.2% in controls. At 30 days, 4.1% versus 3.0%. And importantly, no intracranial hemorrhage. So bleeding increased numerically, but not statistically. So what does this mean clinically? This is not a mortality trial. This is a decompensation prevention trial. You are trading a modest increase in bleeding risk for a substantial reduction in clinical deterioration. The question becomes, which patients are you trying to protect? If you're managing a patient who is stable but clearly at risk, tachycardic, borderline pressure, RV strain, this data supports earlier escalation. But if the patient is truly low-risk intermediate, this may be overtreatment. The takeaway is not treat everyone. It's risk stratification matters more than ever. We've all done this. You look at a CT scan, see a big pulmonary artery, and say, this might be pulmonary hypertension. But how reliable is that? And more importantly, does it matter? This study tackled both questions head-on. They analyzed 691 patients from the PV Domics cohort. Out of those, 595 underwent right heart catheterization. So this is not imaging alone. This is imaging correlated with hemodynamics. The first key finding is correlation. Pulmonary artery diameter correlated with mean pulmonary artery pressure with a Spearman rho of about 0.56. Same for PA to aorta ratio. So moderate correlation, not perfect. Now let's look at actual numbers. As disease severity increased, so did PA size. From no pH to mild pH to moderate severe pH, PA diameter increased from about 27.6 millimeters to 30.6 millimeters to 36.0 millimeters. That's a clear gradient. Now here's where it gets clinically interesting. Diagnostic performance. The AUC for detecting mean pulmonary artery pressure greater than 20 millimeters of mercury was 0.834 for PA diameter, 0.816 for PA to aorta ratio. That's good, not great. Optimal cutoff? About 30.8 millimeters. That gave you 75% sensitivity and 81% specificity. So again, useful but not definitive. But the most important finding was not diagnosis, it was prognosis. Transplant-free survival decreased progressively as PA size increased. And when you compare the highest quartile to the lowest, hazard ratio was 2.36 for PA diameter. That's more than double the risk. So what does this mean for your practice? This is not a diagnostic test. It's a risk signal. A large pulmonary artery on CT should not make you diagnose PH, but it should make you act. It should lower your threshold for echo, for referral, for further evaluation. Because even mild elevations in mean pulmonary artery pressure now matter, and CT might be your earliest clue. Sarcoidosis is one of those diseases where treatment decisions often feel intuitive. But when you step back, the physiology tells a different story. At its core, sarcoidosis is a granulomatous disease. You have activated macrophages, T helper cell signaling, and a tightly regulated inflammatory cascade forming non-caseating granulomas. The key point is this: granulomas are not just inflammation, they are organized immune structures. And that matters because suppressing inflammation does not necessarily eliminate the disease process. Now this is where corticosteroids come in. Steroids blunt inflammation quickly. They reduce cytokine signaling. They shrink granulomas. Clinically, patients feel better fast. But here's the problem. Steroids suppress. They don't cure. And they don't change the long-term trajectory of disease in many patients. So what happens when you taper? The underlying immune dysregulation is still there. And that's why relapse rates are high after stopping steroids. Now let's walk through how to think about treatment more logically. Step 1 is not treat or not treat. Step 1 is who actually needs treatment? Because not all sarcoidosis requires therapy. Patients with mild pulmonary disease, minimal symptoms, often do well without systemic treatment. On the other hand, certain situations clearly require therapy. For example, cardiac involvement, neurosarcoidosis, and severe pulmonary impairment. Those are not optional. Step 2 is understanding treatment goals. You are not trying to normalize imaging. You are trying to preserve organ function, control symptoms, and minimize harm. And that last point is where steroids become problematic. Let's break down steroid toxicity in a way that's clinically practical. Early toxicity happens fast. Within days to weeks, you get glucose dysregulation, mood changes, and sleep disturbance. Within months, you get weight gain, hypertension, and increased infection risk. Within longer timelines, osteoporosis, fractures, and cardiovascular disease. Even low-dose prednisone under 5 milligrams daily is not safe long-term. And here's the part many clinicians underestimate. Toxicity is cumulative. The longer the exposure, the higher the burden. And in one cohort, steroid toxicity was seen in 94% of patients within just 13 weeks. So now let's reframe how steroids should be used. Not as first line for everyone, not as chronic therapy, but as a tool, a short-term tool. The concept introduced in this paper is bridging therapy. You use steroids when you need rapid control. Then you transition early to steroid-sparing agents, ideally within 3 to 4 months. Now let's talk about those alternatives. Methotrexate is the most studied. Mechanistically, it increases adenosine signaling, which suppresses inflammatory pathways differently than steroids. It works slower, but it targets the disease more sustainably. And clinically, it reduces steroid exposure. In one trial, patients required about 50% less prednisone when methotrexate was used. So how do you apply this on rounds? Think in 3 questions. First, does this patient truly need treatment? Second, do I need rapid control? Third, how do I minimize steroid exposure from day 1? Because the biggest shift here is not about adding new drugs, it's about changing mindset. Long-term steroids should not be the plan. They should be the exception. That's the paradigm shift. 3 studies. 3 decisions you'll face in real practice. When to escalate in pulmonary embolism. What to do with a dilated pulmonary artery on CT. And whether steroids and sarcoidosis are helping or just delaying better therapy. These are not theoretical questions. These are decisions you'll make this week. If you want to stay current without reading every paper, this is built for you. And if you're interested in more evidence-based updates in pulmonary and critical care, you'll want to check out our recent episodes covering sepsis guidelines and pleural disease diagnostics. Until next week, this is Dr. Aladdin Sagar, signing off.